Hi, and welcome to Mindful, Beautiful, and Thriving, a podcast series by Taarika Foundation focused on youth mental health. Before we begin today's episode, I just wanted to let you all know that all content that is found in our podcast is created for informational purposes only. This content is not intended to be a substitute for professional medical advice, diagnosis, treatment, or therapy. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition, and never disregard professional medical advice or delay in seeking it because of something you have heard in this podcast. Thank you so much, and without further ado, let's get started.
Welcome to part one of our series about OCD on the Mindful, Beautiful, and Thriving podcast. This is Natalie.
And this is Dana, and we'll be covering general information and the history of this disorder.
With the rising use of social media, vulnerability has been a key part in building communities. A term circulates the feed every so often, one I'm sure you are familiar with: OCD, Obsessive-compulsive disorder. This three-word complex reminds us of arbitrary words such as impulsiveness or the inability to control urges, but these words do not capture the entirety of its prescription. So then, what is OCD exactly?
Before we get into it, let's look at the history of this disorder. Mental health was first mentioned in ancient Egypt and other ancient civilizations as an imbalance of spirituality or otherwise the work of a godlike figure for the particular culture. This idea continued into the first diagnosis of OCD in the 16th century. However, at this time, it was referred to as scrupulosity. It was based on a moral or religious obsession that would drive the individual to spend countless hours praying or doing other activities to prove their morality and goodwill. Modern OCD has been extended to more than religion. However, the same concepts apply. An obsession or fear, such as not going to heaven or being impure, causing an individual to behave in a particular way, typically abnormal to the community.
OCD was included in the third edition of the DSM, the most commonly used diagnostic manual for mental disorders in the 1980s. It was originally categorized as an anxiety disorder, but has since moved to its own category, called Obsessive-compulsive and related disorders. In the DSM-5, or the most recent DSM, related disorders include hoarding disorder, skin picking and hair pulling disorders, and body dysmorphic disorder.
So clearly, this abstract system of OCD has fluctuated over the years. Today, the National Institute of Health outlines it as, quote, a long-lasting disorder in which a person experiences uncontrollable and reoccurring thoughts, known as obsessions, engages in repetitious behaviors known as compulsions or both. People with OCD have time-consuming symptoms that can cause significant distress or interfere with daily life.
Now, let's observe the last phrase of that definition: interferes with daily life, and the three most common types of OCD according to the Mayo Clinic. What can this look like? Well, first, we have contamination OCD, which stems from an irrational fear of contamination. Contrary to its belief that it isn't harmful, it actually can lead to destructive actions. Oftentimes, this fear is so great, it pushes patients to wash their hands excessively or even avoid pathways that can make a trip shorter because they categorize it as a contaminant. Washing your hands excessively can strip your hands of its natural oils and make them raw, and taking longer trips to avoid certain areas can take a toll on one's mental health. From the stress of memorizing every location in order to subdue their fear.
Next, harm OCD stems from intrusive thoughts of losing control and injuring oneself or others. These often come in the form of mental images and acting on one's impulses to bring these images into reality. However, those with harm OCD likely do not have a history of violence, as they do not act on these thoughts. The obsession, however, is purely a fear that they may act on these thoughts. Common compulsions include asking others if they were harmed by the patient, avoiding places or situations that could cause the obsession to arise, or avoiding any sort of sharp object. This negatively affects a person's ability to have a lot of life experiences. People suffering from harm OCD often do not allow themselves to be with children or the elderly alone, so they may miss out on those bonding experiences. Additionally, situations that include sharp objects such as pens and pencils may be inevitable in life and work. These difficulties put a strain on one's livelihood, as without work, living comfortably is hard.
And this last one we'll look over is balance-related OCD, often seen in televised shows like Grey's Anatomy. A quick side tangent, I actually do like its portrayal in Grey's because it shows that disorders can happen to doctors too, and not just the patients we see. Back on track, this disorder can be a physical need, such as putting the same amount of pressure on each foot while walking or placing items symmetrically. In other instances, it can be a mental need, such as requiring everything to occur in either threes or pairs, depending on the patient. Regardless, it tends to lie on the more destructive side of the spectrum because either the action leads a patient into doing something harmful or the failure of completing an action amplifies their fear until they mentally and physically break down. This restricts patients from being able to complete necessary tasks, even from the start, like getting out of bed. In all, it stops the cycle of a healthy daily life.
Much like many other mental disorders, there's no clear outline to a treatment because of its ambiguity. However, there are many solutions that doctors have engineered to administer to patients. This is usually based upon the history of the patient and, more importantly, how they developed the disorder. Though it is hard, we can gather some aspects that could have led the patient to develop the disorder. Oftentimes, there isn't just one catalyst to their condition. It can be a buildup of constant affliction, though in other cases, it stems from a singular traumatic event. Thank you for listening. In the next episode of the OCD series, we will be discussing OCD in the individual and their relationships.
You are listening to Mindful, Beautiful, and Thriving, a podcast series by Taarika Foundation. As part of our youth series, we will be releasing new episodes every Friday, so make sure to continue to check those out. We hope you enjoyed this podcast, and thank you so much for listening.